This video presentation will focus on the temporal and infratemporal fossae. To begin, I would like to introduce the pertinent osteology of the lateral neural cranium and that of the visceral cranium, which is the facial skeleton. The frontal bone, as shown here, is united with the parietal bone via the coronal suture. The occipital bone is posteriorly positioned, and on the lateral skull is the temporal bone, shown here by the X. Recognize that the temporal bone has two parts, a squamous part, shown here, which is the flat portion, and it also has a petrous portion, which you'll see from an internal cranial perspective. The parietal bone fuses with the occipital bone via the lambdoid suture, and the parietal bone fuses with the temporal bone at the squamous suture. Neighboring the temporal bone anteriorly is the sphenoid bone, shown here in pink. The sphenoid bone is made up of both a greater and a lesser wing. The wing shown here is the greater wing. The area of fusion between the frontal bone, parietal bone, temporal bone, and the sphenoid bone is referred to as the pterion, as shown here. This area of the skull is relatively thin, and as such the pterion represents a weak point in the skull. If the pterion is damaged, it may lead to rupture of the middle meningeal artery, which courses just deep to this area of the skull. The temporal bone in particular has several bony features and landmarks. For example, here's the mastoid process, located just behind the external auditory meatus. The sternocleidomastoid muscle inserts here onto the mastoid process. The styloid process shown here is a very pointy prominence of the temporal bone. As you'll learn in subsequent presentations, there are several muscles and a ligament that attach to this process. The opening in the lateral temporal bone is for the external auditory meatus, as shown here. This is the external ear canal. The zygomatic process of the temporal bone helps to make up the zygomatic arch, which is connected to the zygomatic bone anteriorly, shown here in blue. The zygomatic bone is considered the cheekbone. Anteromedial to the zygomatic bone is the large and broad maxilla, or maxillary bone. This bone represents the upper jaw. And shown above in blue is the nasal bone. As we'll discuss in just a moment, the head of the mandible, as shown here, articulates with an area of the temporal bone referred to as the mandibular fossa. Here's the mandibular fossa of the temporal bone. Now let's discuss the osteology of the mandible. In general, the mandible has three main parts. The first part is the chin, which is referred to as the mental protuberance. The mandible also has a body, which is large and broad, and a more vertically oriented ramus, as shown here. Projecting superiorly and anteriorly from the ramus is the coronoid process. And projecting posteriorly and superiorly from the ramus is the condylar process. This condylar process is made up of the head of the mandible and the neck of the mandible. Just lateral to the mental protuberance, there is an opening referred to as the mental foramen. Through this opening, the mental nerve will pass to innervate the skin over the chin. In observing the mandible from an internal perspective, there are a few more features. The tongue-like bony projection on the inside of the mandible is referred to as the lingula, as shown here. The lingula is a very important palpable landmark for dentists. This is because the inferior alveolar nerve courses adjacent to the lingula as it passes through the mandibular foramen. This nerve is anesthetized when performing procedures on either the lower teeth or jaw. As such, dentists palpate the lingula and inject the anesthetic immediately adjacent to it. We'll revisit the inferior alveolar nerve in a subsequent slide. As it turns out, fractures of the mandible are fairly common. Fractures usually occur as a result of motor vehicle accidents, sports injuries, or fights. There are a variety of different types of fractures which can occur in different regions of the mandible. For example, posterior displacement of the mandible can lead to condylar fractures. Simple fractures are often vertically oriented fractures involving the body of the mandible. Green stick fractures, which are more common in children, are partial fractures of the mandible, as shown here. And here is an example of a comminuted fracture of the mandibular body. So how would you classify this fracture in the lower left of the screen, shown here? This looks to be a simple fracture of the mandibular body. Patients who present with mandibular trauma are at higher risk for mandibular fractures. These patients are likely to have jaw pain and perhaps malocclusion of the teeth, meaning that the teeth don't line like they normally do. And this misalignment can make biting or chewing feel very abnormal for the patient. Numbness of the teeth or numbness to the skin of the lower lip and chin is also common in patients with mandibular fractures. Depending on the severity of the fracture, oral surgery may be needed. Now let's take a closer look at the temporal mandibular joint, abbreviated TMJ. The temporal mandibular joint is a bilateral synovial joint which is formed by the condyle of the mandible and the mandibular fossa of the temporal bone. Like other synovial joints, the temporal mandibular joint has an external joint capsule, and the joint is also strengthened and reinforced by several extracapsular ligaments. The ligament immediately surrounding the joint capsule is referred to as the lateral ligament, or it's also known as the temporal mandibular ligament. This ligament runs laterally from the articular tubercle of the temporal bone to the mandibular neck. This bump here represents the articular tubercle of the temporal bone, and here is the neck of the mandible. The sphenomandibular ligament, as shown here, helps to anchor the medial ramus of the mandible to the sphenoid bone. And lastly, the stylomandibular ligament, shown here, connects from the styloid process down to the angle of the mandible. Collectively, these ligaments help to prevent the mandibular condyle from slipping inferiorly out of the mandibular fossa. If we peer into the joint, you'll notice that it's comprised of both a superior and an inferior compartment, and those compartments are divided by something referred to as the articular disc, as shown here. This articular disc is made up of fibrocartilage. In general, the temporal mandibular joint is classified as a modified hinge joint. This is because in addition to hinging, it also allows for gliding movements. Here in this image, the area indicated by the X represents the superior compartment of the joint, which permits gliding movements in both the anterior and posterior direction. The anterior movement of the mandible is referred to as protrusion, whereas the posterior movement of the mandible is referred to as retraction. Now let's do a demonstration. Take your finger and stick it into your external auditory meatus, which is your ear canal. Now slightly open your mouth and protrude your jaw forward. Now retract it. This allows you to feel very nicely the gliding movement accomplished by the superior compartment of this joint. The inferior compartment of the joint, indicated here by the X, is what allows you to accomplish the hinge-like motion of the joint, which is going to allow the joint to both depress and elevate. So depression of the mandible allows you to open your mouth. Elevation of the mandible allows you to close your mouth. In addition to both gliding and hinge-like movements, the jaw is also capable of lateral movements. Lateral movements of the mandible occur most frequently during mastication, which is the chewing process. This slide reinforces the main movements of the mandible at the temporal mandibular joint. Notice that on this slide we also have the muscles associated with each movement. For example, elevation of the mandible is accomplished mostly through the temporalis muscle, the masseter muscle, and the medial pterygoid. We'll see these muscles in just a moment. Depression is accomplished by both gravity and the suprahyoid muscles. Recall these suprahyoid muscles were presented previously in the neck lecture. Protrusion of the mandible is accomplished mostly by the lateral and medial pterygoids. And lastly, retraction of the mandible is mostly accomplished by the posterior fibers of the temporalis muscle. Under normal circumstances during movements of the jaw, the mandibular condyle, shown here, is situated immediately posterior to the articular tubercle, shown here. When the lower jaw opens during depression, the mandibular condyle moves forward to lie just below the articular tubercle. And when we close our mandible during elevation, the condylar process moves posteriorly to lie once again underneath the mandibular fossa, shown here. On occasion, the mandibular condyle fails to return to the mandibular fossa. For example, during excessive yawning, while biting into a hard apple, or during other activities, an exaggerated opening of the jaw has the potential to lock the jaw anteriorly in front of the articular tubercle. When that happens, this is referred to as an anterior jaw dislocation. This is also known as lockjaw. And as you might imagine, having the mandibular head sit in front of the articular tubercle is quite painful. Once the jaw is anteriorly dislocated, it cannot be closed. It's locked into its position, and as such, it has to be forcibly returned to the mandibular fossa. To accomplish this, the examiner will first wrap his or her thumbs in gauze, just in case they get bit, and then they'll place their thumbs inside the mouth and will pull down on the lower jaw. In pulling down on the mandible, they will also retract the mandible back into the mandibular fossa. Without depressing the mandible first, the mandibular condyle is simply going to hit against the articular tubercle. So depression of the mandible must occur before retraction of the mandible to place it back in the mandibular fossa. If you have the time, I encourage you to take a few minutes to watch this video on how to reset a dislocated jaw. For the remainder of this presentation, we'll focus our attention on both the temporal and infratemporal regions. These fossae are interconnected spaces which are located on both the lateral surface of the face and comprise the area of the deep face. The boundaries of these spaces are formed by bone and soft tissue, and each of these spaces will contain different contents. The dividing landmark between the temporal fossa above and the infratemporal fossa below is the zygomatic arch, outlined here in blue. The space between the zygomatic arch and the lateral skull is how there is communication between these two fossae. This space is shown here. In relationship to the zygomatic arch, we say that the temporal fossa sits superior and medial to the zygomatic arch, and it will communicate inferiorly with the infratemporal fossa, which is a wedge-shaped space located inferior and medial to the zygomatic arch. The temporal fossa is a shallow depression situated on the lateral surface of the skull. The temporal fossa is limited anteriorly by the posterior surface of the zygomatic process of the frontal bone, shown here, and the posterior aspect of the frontal process of the zygomatic bone, shown here by the triangle. These structures separate the temporal fossa posteriorly from the orbit. Superiorly, the temporal fossa is defined by the temporal lines, as shown here. And the lateralmost boundary of the temporal fossa consists of the temporal fascia, as seen here. This temporal fascia represents a very tough, fan-shaped aponeurosis, which overlies the temporalis muscle. And between the zygomatic arch and the greater wing of the sphenoid bone, the floor of the temporal fossa is open inferiorly to the infratemporal fossa. The most prominent structure of the temporal fossa is the temporalis muscle, and of course this muscle requires neurovascular supply. This means that arteries, nerves, and veins will course through this area as well. The temporalis muscle, as shown here, consumes the temporal fossa. This muscle is one of 4 muscles of mastication. Again, mastication refers to chewing. The temporalis muscle originates here in the temporal fossa, and it sends its fibers anteriorly and inferiorly to insert onto the coronoid process of the mandible. The muscle fibers of the temporalis, which are more vertically oriented, such as those here toward the anterior aspect of the fossa, will assist in elevating the mandible, whereas those fibers which are more horizontally oriented along the posterior inferior aspect of the fossa are going to be responsible for helping to retract the mandible. And as a reminder, elevation, depression, protrusion, and retraction require the muscles bilaterally work in concert with one another. Unilateral contraction of the temporalis muscle will result in a lateral movement of the mandible, which is important for grinding food. Along its undersurface, the temporalis muscle is supplied and innervated by deep temporal arteries and deep temporal nerves. The deep temporal arteries arise from the maxillary artery, which courses through the infratemporal fossa, and the deep temporal nerves arise from V3, which is the mandibular division of the trigeminal nerve. Now let's peer into the infratemporal fossa and explore its contents. Notice in this image, part of the zygomatic arch as well as the zygomatic bone have been resected in order to peer into the infratemporal fossa. In addition, a large portion of the ramus of the mandible has been removed as well. And so this area here represents the area of continuity or continuation between the temporal fossa above and the infratemporal fossa below. The medialmost boundary or aspect of the infratemporal fossa is bounded by the lateral plate of the pterygoid process, as shown here with the X. This is a part of the sphenoid bone. And laterally, the infratemporal fossa is limited or bound by the medial surface of the ramus of the mandible, which again has been cut away from this image. And anteriorly, the infratemporal fossa is bounded by the posterior aspect of the maxilla. Both the external auditory meatus and the styloid process represent the posterior boundaries of this area. There are a number of structures contained within the infratemporal fossa, including 3 of the 4 muscles of mastication, specifically the medial pterygoid, the lateral pterygoid, and the insertion point of the temporalis muscle. The 4th muscle of mastication is the masseter, shown here with the X. This muscle sits just lateral to the body and ramus of the mandible. Other important structures of this area include the mandibular nerve, V3, which is the mandibular division of the trigeminal nerve and all of its branches. In addition, associated with that nerve, there is a parasympathetic ganglion referred to as the otic ganglion. Neither this nerve nor the ganglion are visible from this image. In addition, there's an important vessel running through this area referred to as the maxillary artery. The maxillary artery will give off a number of branches to the deep face, and intertwined around it is the pterygoid venous plexus of veins. Now let's take a closer detailed look at all of the contents of the infratemporal fossa, and let's begin with the lateral pterygoid muscle. Like the other muscles of mastication, the lateral pterygoid muscle is paired, one on either side. More specifically, this particular muscle happens to have 2 parts. It has a superior head, as shown here, and an inferior head. The superior head of the lateral pterygoid attaches from the greater wing of the sphenoid bone to the articular disc and the joint capsule of the temporal mandibular joint. In comparison, the inferior head is much larger than the superior head. This head will attach from the lateral pterygoid plate, specifically the lateral aspect of this plate, and it will reach all the way to the neck here of the mandible. If we view this muscle from a posterior perspective, you can see the superior and inferior heads, and notice how the inferior head attaches to the medial neck of the mandible. Also notice from this perspective, there are 2 plates, the medial and lateral pterygoid plates. This is the medial plate here, and here's the lateral plate. In the image to the right, here is the medial pterygoid plate, and here is the lateral pterygoid plate. Therefore, the lateral pterygoid muscle, the inferior head that is, attaches from the lateral aspect of the lateral pterygoid plate to the neck of the mandible. Because of the very horizontal orientation of these fibers, especially of the inferior head, the lateral pterygoid muscle will act bilaterally to protrude the jaw. When contracting unilaterally, this muscle can also help to produce lateral movements of the jaw for grinding food. During dissection, in order to visualize a number of the nerves and vessels of this region, you will need to resect a large portion of the lateral pterygoid muscle, roughly in this area here. Most of what you'll resect will be the inferior head of the lateral pterygoid. This muscle, like the medial pterygoid muscle, receives its nerve supply from branches of the mandibular nerve, V3. It will receive its arterial supply from branches of the maxillary artery. Now let's discuss the medial pterygoid muscle. Again, as a quick review, here are the medial and lateral pterygoid plates respectively. The medial pterygoid muscle attaches to the medial side of the lateral pterygoid plate. So in the image to the left, it's attaching here. And the medial pterygoid muscle will insert onto the medial surface of the ramus of the mandible near the angle of the mandible, as shown here. When the medial pterygoid muscles contract bilaterally, they assist in elevating the lower jaw. The other muscles contributing to lower jaw elevation include the temporalis muscle and the masseter muscle. And when a single pterygoid muscle contracts unilaterally, medial pterygoid muscle that is, it will deviate the jaw toward the contralateral side, again allowing for these lateral movements of the mandible. And just like the lateral pterygoid muscles, the medial pterygoid muscles also receive their innervation from branches of the mandibular nerve, V3, and they receive their arterial supply from branches of the maxillary artery. And the last muscle of mastication lies just lateral to the ramus of the mandible. This is the masseter muscle. The masseter muscle attaches from the undersurface of the zygomatic bone and the anterior portion of the zygomatic arch. And this muscle inserts here on the lateral surface of the mandible in the area of the angle of the mandible and lies over top of the ramus. Of the muscles that elevate the mandible, the masseter is the most powerful elevator. The masseter is innervated by a branch of the mandibular nerve V3, specifically the masseteric branch, and it's also supplied with arterial blood via branches from the maxillary artery. You may be able to visualize this nerve-artery pair during dissection. As you may recall from a previous presentation, the external carotid artery, abbreviated here ECA, terminates as both the superficial temporal artery and the maxillary artery, shown here. The maxillary artery courses behind the ramus of the mandible to enter into the infratemporal fossa. And within the infratemporal fossa, it will give off a number of branches. Many of these branches are very small muscular branches which can be very difficult to identify, but there are also some other branches that you'll certainly be on the lookout for. We'll cover these branches in the next slide. Recognize that along its course, the majority of the maxillary artery runs through the infratemporal fossa, as demonstrated here by the purple shading. As the artery courses and makes its way closer to the center of the head, it enters into the pterygopalatine fossa, as shown here. We will return to this pterygopalatine fossa in a later presentation. For now, simply understand that the maxillary artery will give off its terminal branches here within the pterygopalatine fossa. And above the infratemporal fossa, as you now know, lives the temporal fossa. This is where the temporalis muscle is housed, and this is where those deep temporal arteries will course. Now let's take a look at the highest yield branches of the maxillary artery. The branches of greatest interest are outlined in red. Here again we have the external carotid artery, branching into the maxillary artery, which enters into the infratemporal fossa, and it also terminates as the superficial temporal artery here. Arising from the first part of the maxillary artery and heading inferiorly to the lower jaw is an artery referred to as the inferior alveolar artery. This artery courses right next to that lingula of the mandible, and it enters into the mandibular foramen. After entering the mandibular foramen, it courses through a bony tunnel within the mandible, and it will emerge onto the face, in the area of the chin, at the mental foramen. Once this artery emerges onto the chin, it changes names to become the mental artery. Arising from the superior aspect of the first part of the maxillary artery is a very important middle meningeal artery, shown here. This middle meningeal artery enters the cranium through the foramen spinosum. And once inside the cranium, it gives off both an anterior and posterior branch. In a moment, we will see an important nerve-artery relationship which involves the middle meningeal artery. Specifically, the auriculotemporal nerve forms a donut ring through which the middle meningeal artery passes. You'll be on the lookout for this nerve and this ring in dissection. Arising from the proximal end of the second part of the maxillary artery are usually a number of deep temporal arteries, as shown here. Recall these deep temporal arteries are responsible for supplying blood to the temporalis muscle. While during dissection you may come across the arteries branching to the lateral pterygoid, the medial pterygoid, the masseter, and even the buccinator muscle, these arteries are of lower yield. At the distal end of the maxillary artery, once it has entered into the pterygopalatine fossa, there are a number of additional branches. 3 of these branches we will revisit in greater detail in subsequent presentations, but let me introduce you to them now. This branch is the descending palatine branch. This artery descends through the greater palatine canal, and it exits onto the hard palate via the greater palatine foramen. It will supply both the hard palate and the soft palate. The infraorbital artery will course just under the floor of the orbit, and it will exit via the infraorbital foramen onto the face to supply the area of the maxilla. And lastly, the sphenopalatine artery will supply blood to the nasal cavities. This slide gives you a better perspective of how the maxillary artery relates to the bony structures of the face. So let's review. Here is the inferior alveolar artery, which enters into the mandibular foramen roughly in this area here. It courses through the bony conduit of the mandible, and it exits onto the chin here at the mental foramen as the mental artery. Here you can visualize the middle meningeal artery, which is entering the cranium through the foramen spinosum. Here are examples of deep temporal arteries which supply the temporalis muscle. Here the sphenopalatine artery is entering into the nasal cavity. Here you see the infraorbital artery coursing along the floor of the orbit to exit here at the infraorbital foramen so as to supply the skin and muscles overlying the maxilla on the anterior face. The venous drainage of the infratemporal fossa is by route of the pterygoid venous plexus. This plexus exists bilaterally, and it overlies the individual lateral pterygoid muscles. The pterygoid venous plexus, along with the ophthalmic veins, maintain direct connections with the cavernous sinus in the middle cranial fossa. These connections to the cranial cavity through the emissary veins means that infections which are extracranial can spread intracranially through this venous plexus. The veins of this plexus are valveless, meaning there is the potential for a retrograde flow of blood to occur as the result of a pressure differential. Therefore, if there are infectious agents or pathogens within the blood, that blood can be carried intracranially in the blink of an eye. In other words, a manageable extracranial infection can quickly turn into a very dangerous intracranial infection. The venous blood of the pterygoid plexus will be returned to either the internal jugular vein or the external jugular vein, or both. Notice how the veins of this plexus reunite to form the maxillary vein, and when the maxillary vein unites with the superficial temporal vein, together they form the retromandibular vein, abbreviated here RMV. The retromandibular vein has 2 divisions. It has a posterior limb, which unites with the posterior auricular vein to form the external jugular vein, as shown here. The anterior limb of the retromandibular vein will continue on inferiorly to unite with the facial vein. Together, they form the common facial vein, which drains directly into the internal jugular vein. And this is how the majority of blood is drained from the infratemporal fossa. And lastly, let's explore the mandibular nerve and the many branches it gives rise to within the infratemporal fossa. The mandibular nerve, also known as V3, is a branch of the trigeminal nerve, cranial nerve number 5. The mandibular nerve enters into the infratemporal fossa via the foramen ovale, as shown here. And once inside the infratemporal fossa, it gives rise to several motor and sensory branches. And do recognize that the cell bodies of the sensory neurons conveyed through this nerve are housed here in the trigeminal ganglion, also referred to as the semilunar ganglion. Let me also remind you that the mandibular nerve is the only branch of the trigeminal nerve which has a motor component to it. Neither V1, the ophthalmic nerve, nor V2, the maxillary nerve, contain motor fibers. These nerves are purely sensory. As we have already discussed, several branches of the mandibular nerve will supply motor innervation to the muscles of mastication. For example, here are the deep temporal nerves, supplying motor innervation to the temporalis muscle. Likewise, there are smaller nerves to the lateral pterygoid, medial pterygoid, and masseter muscle as well, which arise from V3. Of those nerves that supply the muscles of mastication, the deep temporal nerves are the easiest to locate during dissection. The mandibular nerve also carries sensory information from a variety of different structures. For example, it carries sensory information from the teeth, the mandibular gingivae, which are the gums of the lower jaw, from the anterior 2/3 of the tongue, from the mucosa on the inside of the oral cavity, from the lower lip, and even from skin of the temporal region in the lateral and lower face. One of the sensory nerves of interest is the buccal nerve, shown here. This nerve is sometimes referred to as the long buccal nerve by dentists. They refer to it as the long buccal nerve so as not to confuse it with the buccal branch of the facial nerve. Recall that the buccal branch of the facial nerve innervates the buccinator muscle. This buccal nerve, however, is purely sensory, and it will only pierce the buccinator muscle in order to carry sensory information from the oral mucosa along the inside of the cheek. It will also carry sensory information from the skin overlying the cheek. The inferior alveolar nerve is another very important sensory nerve which conveys sensory information from the teeth of the lower jaw. It will also convey sensory information from the skin which overlies the chin via the mental nerve, which is the very first portion of this nerve before it enters into the mental foramen. As soon as it enters the mental foramen, this nerve changes names to the inferior alveolar nerve, and it makes its way back to the main mandibular nerve, V3. Do notice that a portion of the inferior alveolar nerve does carry motor fibers. It gives off the nerve to the mylohyoid here, which is carrying motor innervation to the mylohyoid muscle. The lingual nerve, shown here, will carry both taste and sensory information from the anterior 2/3 of the tongue. Recognize that the nerve fibers conveying taste information do not course back through the mandibular nerve. Instead, they course through the chorda tympani, which we'll see in just a moment. The lingual nerve does, however, carry sensory information from the anterior 2/3 of the tongue back to the mandibular nerve, and from there, back to the trigeminal nerve. And lastly, here's the auriculotemporal nerve. This nerve has a pair of roots which surround the middle meningeal artery. The auriculotemporal nerve carries parasympathetic fibers to the parotid gland in order to stimulate salivary gland secretions. In addition, this nerve will carry sensory information from the parotid gland as well as from the temporal region of the scalp. And any pain felt from the temporal mandibular joint is conveyed through the auriculotemporal nerve. Here's a second look at the inferior alveolar nerve, which is carrying sensory information from the lower teeth, the mandibular gingivae, as well as the skin of the chin and the lower lip by route of the mental nerve. And here is the nerve to the mylohyoid muscle, which again is a motor nerve going to the mylohyoid. In addition, the nerve to the mylohyoid also innervates the anterior belly of the digastric muscle. Here, the lingual nerve is carrying sensory information from the anterior two-thirds of the tongue, as well as conveying taste information back through the chorda tympani nerve, which is shown here, which is associated with cranial nerve number 7, the facial nerve. More on that in just a moment. And here's the very characteristic auriculotemporal nerve with its roots surrounding the middle meningeal artery. Again, the auriculotemporal nerve is responsible for carrying sensory information from the parotid gland and the temporal region, and it also conveys postganglionic parasympathetic fibers to the parotid gland. Those fibers originated from the glossopharyngeal nerve, cranial nerve number 9. And lastly, the chorda tympani nerve, as shown here, is responsible for conveying fibers regarding taste from the anterior two-thirds of the tongue, and it's also going to convey parasympathetic information to both the submandibular and the sublingual glands. Here's a closer look at the chorda tympani nerve. The chorda tympani is the third branch of cranial nerve number 7, the facial nerve. It actually branches from the facial nerve within the skull. Here you see the chorda tympani nerve branching from the facial, and it's exiting the petrotympanic fissure in order to enter into the infratemporal fossa. Before the chorda tympani nerve exits the base of the skull, notice how it courses through the middle ear cavity and it loops over top of the tensor tympani muscle. If middle ear surgeries are performed, the chorda tympani nerve is at high risk for injury. If this nerve is injured, patients can present with diminished taste from the anterior two-thirds of the tongue, and they can also present with diminished salivation or decreased salivation. After the chorda tympani nerve courses through the middle ear cavity, it exits the base of the skull at the petrotympanic fissure, which is a small crack shown here on the undersurface of the skull, adjacent to the mandibular fossa and the styloid process. Once the chorda tympani enters into the infratemporal fossa, it very quickly unites with the lingual nerve, as shown here. The lingual nerve then carries its fibers forward to the tongue, or in the case of taste, it carries its fibers back from the tongue to the chorda tympani. The parasympathetic fibers, which are destined for the sublingual and submandibular salivary glands, originate from cranial nerve number 7, the facial nerve, as shown here. Preganglionic parasympathetic fibers are conveyed through the facial nerve, course through the geniculate ganglion, and exit via the chorda tympani nerve. From the chorda tympani, they jump onto the lingual nerve, and here is the submandibular ganglion where the synapse between pre- and postganglionic parasympathetic fibers occurs. The postganglionic parasympathetic fibers either jump back on to portions of the lingual nerve to be carried forward to the sublingual gland, or the submandibular ganglion just gives off small branches to the neighboring submandibular gland. And this is how parasympathetics innervate the sublingual and submandibular glands. Using this image, let me also point out that all of the glands below the oral fissure are innervated by the chorda tympani nerve, whereas those glands above the oral fissure are innervated by the greater petrosal nerve, which is also a branch of cranial nerve number 7, the facial nerve. This image is simply meant to reinforce the pathway of the pre- and postganglionic parasympathetic fibers. Again, the preganglionic parasympathetic fibers originate from the facial nerve, cranial nerve number 7. They are conveyed through the chorda tympani, and those preganglionic fibers meet up with the lingual nerve to be carried to the submandibular ganglion. From the submandibular ganglion, small branches are either given off to convey the postganglionic fibers to the submandibular gland, or the postganglionic fibers jump back on to the lingual nerve in order to be conveyed to the sublingual gland underneath the tongue. do recognize that knowing these various parasympathetic pathways can be very important and useful for helping to localize cranial nerve lesions. This concludes the video on the temporal and infratemporal fossae. Happy studying!